Hello and welcome to JAMA Network Open Conversations. I'm Dr. Angel Desai, Associate Editor for JAMA Network Open. Today we are speaking with Dr. Barbara Jones and Dr. Michael Klompas about incidence and outcomes of non-ventilator-associated hospital-acquired pneumonia in 284 U.S. hospitals using electronic surveillance criteria. Welcome.
Thank you.
Thank you.
To start, can you please both introduce yourselves?
Sure. My name is Barbara Jones. I'm a pulmonologist and critical care physician at the University of Utah and the VA in Salt Lake City, Utah.
And I'm Mike Klompas. I'm an infectious disease physician and the hospital epidemiologist at Brigham and Women's Hospital in Boston.
Great. To start off, can you tell us a bit about the background of the study and what prompted your interest in this topic?
A few surveillance studies from CDC and from the European Public Health Agency have told us that hospital-acquired pneumonia is probably the most common healthcare-associated infection, and that most of the cases actually occur in non-ventilated patients as opposed to ventilated patients, and probably is associated with the highest crude mortality rate of any healthcare-associated infection. Despite that, most hospitals don't have active programs to track non-ventilator hospital-acquired pneumonia or to prevent non-ventilator hospital-acquired pneumonia, and so it seems like a real gap. There is a strong history of surveillance for ventilator-associated pneumonia or ventilator-associated events and prevention programs, but nothing equivalent for non-ventilator hospital-acquired pneumonia, and it seems to be more common and just as bad as ventilator-associated pneumonia or events.
Another really challenging thing about pneumonia is that it is a pretty fuzzy syndrome. It's very subjective. So attempts to track it in the past have relied on diagnosis codes and chart review and manual assessments of chart review. And both of these are very difficult to know that all things being equal, hospitals across the country can be tracking the same thing. And so even over time, diagnosis codes shift and change. And so we really have been limited, and the whole science of the pathogenesis of hospital-acquired pneumonia is really limited by a fuzzy syndrome that has a not great definition that is not easily captured in a system-level way.
So the key magic for us was to try to come up with a way to be able to identify non-ventilator hospital-acquired pneumonia in a consistent, efficient, electronic, reproducible way, so that we could give hospitals a tool to identify this phenomenon, to track what's happening over time, to look and see what's happening to mortality rates. If they put in place a prevention program, to look and see whether it's working or not. That was sort of the foundation. We needed a tool to enable efficient and reliable surveillance.
And to follow up on that, what would you say are some of the inherent challenges with measuring the incidence of non-ventilator-associated hospital-acquired pneumonia? And maybe you can talk a bit about what the advantages are potentially of using an electronic clinical surveillance definition versus some of the other methods that you mentioned.
So in terms of the challenges, challenge number one is that a lot of patients are at risk, right? So in other words, the population of individuals in the hospital who are not on a ventilator can be enormous, running to hundreds of people that need to be tracked. Number two is that the bedside criteria that people use to diagnose pneumonia are pretty fuzzy. Does a patient have a new infiltrate or not? What you think is a new infiltrate might be different from what I think, whether it's due to fluid or atelectasis or something else, or poor body position or pneumonitis or whatever, can be very difficult for people to choose between. And if you want to do your surveillance using positive microbiological cultures, which is a standard approach for looking for, say, bloodstream infections or catheter-associated urinary tract infections or surgical site infections or C. diff, you can't do that because only a minority of people who have pneumonia produce sputum that's sent to the lab for culture. And so if you were to look at positive sputum cultures alone, not only would you miss a huge number of the potential pneumonia events, but you also have the problem of overclassification, because of course not every positive sputum culture is associated with true pneumonia, some of it's colonization alone. So there's no good hook to try to identify the population of patients who have non-ventilator hospital-acquired pneumonia. And as Barb was saying, so what people have done historically speaking is they've used diagnosis codes. But we know that diagnosis codes are really just a function of people's bedside clinical impressions, which we just said a moment ago are pretty challenging and differ between people. And so you really just get it with diagnosis codes, you get a reflection of some of that thinking from the bedside, as imperfect as it is. And we know from validation studies that the positive predictive value for a diagnosis code for hospital-acquired pneumonia is incredibly poor. So misses cases and overcalls cases as well. So it's not a good strategy.
We developed criteria that use only clinical data. And when I say clinical data, what I mean is routinely collected clinical variables that are obtained from the electronic health record. These include vital signs. So did the patient have an abnormal temperature? These include oxygen assessments. So did they have a deterioration in their oxygen needs or oxygen levels? And this also includes labs, so an abnormal white blood cell count. And then also the ordering of a chest image. And we kept this pretty limited number of clinical data that are simple and really routinely collected in every electronic health record. So very implementable across different systems. And the advantage of that is that it is a little bit less subjective than a end of the day diagnosis that you might have in the hospital discharge diagnosis codes. And also the interesting thing is with manual chart review is seen as the gold standard for identifying hospital-acquired pneumonia. But every time we look at this, we see that even using very strict criteria to humans that are clinicians, that are trained reviewers to go over manual chart review, they can still be pretty variable. And they can be variable between two reviewers, but they can also be variable for the same reviewer across time. And so humans are sometimes not the most reliable and consistent. We don't think that the measure or the definition is perfect. We actually have a separate study where we did a really in-depth analysis of the validity of this measure, and that's published in the Infection Control and Hospital Epidemiology journal last March. It shows that our definition isn't perfect, but it's about the same accuracy as the other working definitions that other people have used. And the real advantage is that it's consistent. And so as long as you have good healthcare data, you can implement this. It's also really efficient. And like Mike mentioned, it's really important to be able to do this on a large scale because so many patients are in the hospital, not on ventilators and at risk. So having a scalable, consistent measure that can be automated is really important to be able to screen patients.
Absolutely. Where did the data from this study come from and what did you do?
I'm glad you asked that question. I love data and the thorny issues with this. And this was one of the most exciting things about this project was that we brought two very large data sets from two very large healthcare networks from the United States together. And that was really cool. So I am a researcher at the VA, the Veterans Health Administration. And so we combined the results from a data set from the VA hospitals. So that's 145 VA hospitals across the country, all acute care hospitals. We really focused on acute care hospital beds. And Mike and his team work with the HCA data set, which is 145 VA hospitals and 139 HCA hospitals. And so those are two very large hospital networks across the country. So we developed this surveillance criteria and we programmed this in a SAS code. And actually the SAS code is available in the supplement and on GitHub. And so we tried to make a toolkit for any hospital that wanted to see whether this is a valid way to identify hospital-acquired pneumonia in their settings. They could implement this code. So we shared this code in these two secure data set environments, and then we implemented this code. And actually, just doing that process was really great at refining the measure and testing it into really huge data sets. And then we ran the same analysis in both secure data environments.
What were some of your main findings?
We first of all were able to characterize the incidence of NV-HAP, and the incidence was about 0.55 events per 100 hospitalizations. So in essence, about 1 in 200 hospitalizations was associated with NV-HAP. As you can imagine, that rate did vary quite a bit between hospitals. Some were a bit higher, some were a bit lower. And then strikingly, the mortality rate was very high, around 22% hospital mortality rate, plus an additional 8% of patients end up at hospice. So all told, about 1 in 3 patients who had NV-HAP died or were discharged to hospice. That's a striking finding. Another part of the work was that we worked with a statistician to try to estimate the hospital level what fraction of hospital deaths from any cause might actually be due to NV-HAP, given the fact that we've established now it is pretty common, right? 1 in 200 hospitalizations, and has such a high crude mortality rate. And using a methodology that extrapolated using detailed electronic clinical data, what would happen to hospital mortality if you removed all the NV-HAP cases, we were able to estimate that NV-HAP itself might account for as much as 7% of all hospital deaths due to any cause. Now, it's a big question mark as to how much of that is actually preventable. That's another topic. But in and of itself, it gives you some sense of just the enormity of the burden of this one condition on patients who are hospitalized.
I was surprised both by the significantly increased median length of stay among these patients, but also with the mortality estimates that you mentioned. Do these fall in line with some studies that have used other methodologies, or is there a large discrepancy?
It's very consistent with what others have found using different methodologies for detecting and defining NV-HAP. So across the literature, the crude mortality rate for NV-HAP, depending on who you're reading, what population they're looking at, is anywhere between 15 to 30%. And we found 22%, so right smack dab in the middle of that particular range. And then you mentioned sort of the striking length of stay association. So just for listeners' benefit, the median length of stay for patients with NV-HAP was 17 days, compared to about 4 days for the non-NV-HAP general hospital populations. A big difference.
Clearly very important findings. What do you think, based off of some of the work that you've done here, some of the next important or potentially unanswered questions in this area, or that you may be conducting in the future?
One of the things we have to acknowledge is there definitely are advantages to these digital measures that can really make it scalable. And the key advantage to this is we're going to be able to actually start being able to compare hospitals, but also to unlock what the mechanism of developing pneumonia in the hospital is in the first place. As Mike mentioned a little bit earlier, it's debatable how much of hospital-acquired pneumonia is preventable. So even the understanding of how to prevent hospital-acquired pneumonia, there's a lot of uncertainty around where we should be directing our prevention efforts. And so even just establishing some of the key interventions that are effective to prevent hospital-acquired pneumonia, that's actually a huge step, because now we can actually use clinical data to really understand some of the relationships between patient features, interventions, all sorts of things that we do at the hospital that may increase the patient's risk. So just having a measure that's consistent and can be used across different settings and really look at variation, that's going to be a huge addition to the science. I think that's probably the number one goal, is we just have to improve the science of the pathogenesis of pneumonia that happens in the hospital so we can somehow do something about it.
Yeah, we need to understand better what causes it so we can prevent it. Along those lines, one of the challenges is, or one of the things we found, is that the population of patients who develop NV-HAP is a sick population to begin with. So the average age in this group was a median age of 69. There was a median of 6 comorbidities per patient, so this is a very frail population. Lots of congestive heart failure, underlying neurologic disease, chronic lung disease, cancer. And so the big question is, how much of that very high mortality rate and long length of stay is due to patients' underlying frailties and comorbidities and whatever brought them to the hospital in the first place, versus the additive impact of the NV-HAP? What's actually leading to the pneumonia itself, and what will work to try to eliminate it? That's I think, are the questions that we have to tackle now, in parallel to the work on efficient and reliable surveillance metrics that Barb was describing.
One other thing, as Mike points out, these are really sick patients who end up developing hospital-acquired pneumonia. And so they're going to have high risk of developing hospital-acquired pneumonia and also high risk of having poor outcomes, high length of stay. And if you just kind of look at baseline patient characteristics and a patient's baseline illness severity and try to account for those patient risks and then try to estimate attributable mortality, it can tend to be an exaggeration. Because what happens to patients in the hospital is kind of the old adage is the longer you are in the hospital, the more bad things that can happen to you. And so you're at a higher risk with every hospital day. But what can happen is patients have very dynamic illness severity. They don't just have a fixed illness severity at their first hospitalization day. What we did with the methods is we had a very large daily data set. And so we were able to track the dynamic illness severity for a patient across their entire hospitalization and use that to account for their risk of developing hospital-acquired pneumonia on every given day, and then really use that to account for what they call time-dependent bias, which is the dependency on how many hospital days that you are in the hospital and kind of what your illness severity is on a given day when you develop a pneumonia. So that was a really key feature that really helps lead us to more realistic estimates of what the true attributable mortality is.
I think those are some great thoughts to end on. Thanks so much to Dr. Barbara Jones and Dr. Michael Klompas for speaking with me today about this very important and very interesting topic.
Thanks so much for having us.
Thank you.
This episode was produced by Shelley Steffens at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com. Thanks for listening.